Okay, first of all, I want to thank all of you to be here and to listen me. And the topic that I'm going to cover is the restoration of endodontic treated teeth. And usually this topic is mainly focused on to make the post, to place the post or not to place the post. When we can place the post, where we cannot place the post, or where we can avoid it, if it's better to place or if it's worse to place. Now, this is something that, in my view, is pretty old as a concept. The post is just a tool for restoring endodontic treated teeth. But as a prosthodontist, we have to focus our attention in some other aspects that are, some of them, more important than to place the post or not. So we published in this paper the restorative difficulty evaluation system of endodontic treated teeth inside prosthodontic treatment planning. And in this paper, we went through all the interdisciplinary implication and connections we can face when we have an endodontic treated tooth to be restored. So the question is how to build up endodontic treated teeth, or to evaluate teeth to be endodontic treated inside the treatment planning. So in our view, it's much more important to start from the second question and then to go back to the first one. We have more or less two different kinds of endodontic treated teeth, or teeth generally talking: prosthodontic teeth and endo-restorative teeth. Prosthodontic teeth, as you can see, are teeth that are mainly destroyed, and usually they are in combination with severe grinding of the teeth, so parafunction, severe wear. Endo-restorative teeth are single tooth that pretty often, or a couple of teeth in an arch, that must be restored after endo treatment, but usually this is in a healthy patient, healthy mouth, healthy teeth. So just one or two teeth must be restored. So, but this classification is useful if we want to focus the attention on I place the post or not to place the post. In that case, we move to endo-restorative teeth. But when we talk about prosthodontic teeth, or more extensive treatment, we need to focus our attention, I tell you again, in something different at the beginning. So we have this drawing that is the restorative difficulty evaluation system of endodontic treated teeth. We have the patient, the mouth, and the tooth. When we talk about the patient, about a tooth, about the mouth, so we still talk about the same person, the same issue, the same topic, or is different. So we have to focus our attention on the fact that we have to start with our patient as a human being, as a patient that must be in a good health, then the mouth of the patient, and then the single endodontic treated tooth. And when we have to, what are the parameters, the clinical parameters that we have to look at? Endodontic aspect, residual vertical coronal structure, residual horizontal coronal structure, marginal seal, local interdisciplinary conditions, complexity of treatment planning, functional needs, and dental wear and aesthetic needs. But in what order? Moving from the right to the left in this watch, or moving from the left to the right? So we made, for each parameter, we made two scores that are the more internal, and they are the green light, like the lights when we drive, that are situations that are easy to be performed clinically. In yellow are so-so, are a little bit complex but can be solved. And in red means that, be careful, the tooth has some condition to be extracted. So we may have, for instance, and we have to start, from the patient. Because the patient, is true that he's coming to us for pain pretty often. But after solving the pain, and this is still an emergency step of our job, we need to focus our attention on the mouth of the patient. And then, first of all, the patient. The patient may have a dental wear and aesthetic needs, and we may have a different level of dental wear, from no dental wear to very to compromise function due to the dental wear. And of course, the aesthetic need can be combined, because pretty often the patient, they want to have beautiful teeth and not shorter and wear teeth. So let's see a case in which medium level of difficulty, aesthetic need, and mild dental wear. We have this lady. This lady, she's 50, and she wants to remake the smile, her smile. She wants to improve the smile. She has a personality very energetic and positive, highly collaborative and motivated, very high expectation for aesthetics, mainly for aesthetics. In the medium history, she showed nothing important to be noted. And in dental history, she received recall for oral hygiene and the restorative treatment and crowns. And last dental treatment was 3 months ago, and she received oral hygiene. And her oral hygiene habits was toothbrush twice a day and floss. We made extra oral examination, and we analyze the facial symmetry, and the midline is okay, and then the morphology, the facial morphology is square, and the facial third are balanced. So we look also the profile and 45-degree view of the patient, and then we ask to open to smile, and we look, we make a smile analysis, and we see the incisor edge line, the buccal corridors, and the dental display by the lips. Then we look the rest position, the labial seal, and the smile, and the lip line. And we look the incisors edge line, the harmony of the smile. And we see something that is wrong, something that is not so nice. And when we look from the profile, and 45-degree in particular, we can see that she doesn't have the canine, apparently. And we go now in the clinical oral diagnosis. We look the intraoral examination, and we can see that we have no upper laterals. So we have two laterals. They were the canines that were crowned as laterals. And also we can see that the two first bicuspid, they were rotated in order to fill the space, and the harmony of this upper teeth and the smile was compromised for that. So she has also some filler teeth in posterior area, and the 23, the canine on the left was already endodontic treated. So we have some diastema between the two canine or lateral, as you want to call, and the two bicuspid. And so these are lateral view, and these are the protrusive and lateral movement in the lower line of this patient. We made the periodontal examination, and with the Florida probe, we made this chart. From the chart, you can see that we have a 7 millimeter depth pocket mesially to the lateral or the canine on the right side of the patient. And we can see also in the X-ray that in this area we have a deep bone defect, angular bone defect. The patient has a BOP on 12 on the tooth that has this periodontal lesion, and she's in recall program of oral hygiene every 6 months. So what we do, we design our diagram for difficulty of endodontic treated teeth to be restored inside the treatment planning, and we can see that there is some dental wear and in particular aesthetic need of this patient, but we assume that there are not other important difficulty. The 23, again, the same issue. Aesthetics is the main difficulty, and this can be solved. We have also this X-ray, and in the X-ray, in this, you can see that the patient has the roots of the canine that are filling the space of the lateral and of the canine. So they are more or less a 45 degree, and so we have to exclude, like the patient is now, to place any implants. So this is the black and white picture, the X-ray, the full mouth, and then we go for prosthetic examination. We take a face bow, we mount in the articulator, and then we see the disalignment of lower incisors, and then the rotation of the two bicuspids on the cast. And then, first of all, we thought about Invisalign. So to do an ortho treatment, but not using bracket in the upper, because the patient shows the upper teeth when she smiles, and she is a PR, a public relations, she has a company on that field. So she doesn't want to have any orthodontic pliers. So we sent to Invisalign after scanning. So you know that they can provide from the first shell to the last shell the change that can be done, and you can see that in the upper, what they want to do with Invisalign was to close completely the diastema, completing the rotation of the bicuspid. And that is what we don't want to do for this patient. So in the lower, so you can see from first shell to the last one, there was no significant change. And only in the lower, they may do some realignment of the lower incisors. So we went through digital smile design evaluation. Here we have the shot on the iPad of the patient. So we start to design the position of the teeth we want to have, and then we show to the patient how we would like to bring her teeth. And the patient said, yes, that is what I want. But it's much easier to do on the digital smile design than to do clinically. So, because here you can see on the occlusal view where the teeth should be placed. So, we started to make a traditional wax up in the cast, in the articulator, by the technician, in order to know if we really can derotate the bicuspid and then to place the tooth that was missed in the both sides. And we did the traditional wax up, and that was important. So we also do localized prognosis by sextant. So we have prognosis we follow this procedure that is Jack Caton article, is a system for assigning periodontal prognosis, and we divide periodontically the teeth in favorable, questionable, unfavorable, and hopeless to be extracted. So, and we do sextant by sextant. This was the first sextant in which we do not have any problem periodontally. In the second sextant, we have unfavorable prognosis on the canine that was positioned the lateral because the 7 millimeter poking depth mesially, and the other teeth did not have any specific issue from periodontal point of view. So, what kind of treatment planning we can do? We can do ortho. No, the patient excluded to make ortho in the upper. Implantology is not possible to do. So we have to look point 3 and point 4, surgery and prosto. Why surgery? Because we decide after scaling and root planning to extract the canine in position of lateral with the angular bone defect in order to recreate some room and to have the possibility to manage better the aesthetic of the patient. And when we did the extraction, we also placed temporary bridge from the first bicuspid to the central incisor in both sides. We made the preservation alveolar socket, re-evaluation, ortho treatment in the 5th sextant, and then restoration, removing the old amalgams, and then final bridge. So here you can see that after removing the 2 old crown, we start to prep the central incisors, then we extracted the canine, where we prep also the bicuspid, and after that we made a preservation of alveolar socket, filling the socket with similar bone and the closing with a membrane. And then how to preserve the alveolar socket? Do nothing, bone substitute, or what else? We use bone substitute. So after 1 week with the temporary, you can see the patient, and you can see the tissue that are recovering, and you can see already after 1 week the nicer smile of the patient. She's already satisfied about the aesthetics. Of course, as a first step, but she's comfortable. You can see here. So now we go through the lateral and protosive movement with the temporary. And remember, the temporary for us is our test drive of the final restorations. So these are the prep in the upper after a period of time, after 3 weeks, and we started the ortho treatment in the lower using a static bracket in order to realign the incisors. So these are the answer that the gingival tissue has with the temporary, and this is the occlusal view in which you can see that all the 8 teeth were placed. After 6 months, you can see the patient, how she is still, she's still with temporary, and you can see that the lower teeth are going to be better aligned. So these are the lateral view. You can see the tissue that is going to stabilize itself. You can see the emergence profile of the temporary, and then how we prep. We can make horizontal prep, vertical prep, or hybrid prep. So we did horizontal prep on the incisors, and then we did an hybrid prep on the bicuspid, preparing with a chamfer mesially, and distally and lingually and palatally preparing knife edge in order to gain some space for placing the crown. And you can take impression. In this case, when the tissue are so good and the preparation, the finishing line are juxtagengivally, you can use analog impression, elastomeric materials, traditional, or digital scanners. And do we do gingival displacement? There are many techniques, FE cord, and then we can use adrenaline or ferric sulfate, ferric chloride, aluminum sulfate, aluminum chloride, or nothing. What did we use? We used just one very thin 3-0 suture silk as a retraction cord into the sulcus, no other technique, no other materials, and you can see the teeth, the abutment after the impression, And the impression were taken traditionally using polyvinyl siloxane. Then we took an interocclusal registration in CO, in centric occlusion. And what kind of material we use? We can go to plastic, ceramic, particle filler pressable glass ceramic, lithium disilicate, polymer infiltrator ceramic network, zirconia reinforced lithium silicate, or zirconia. For this particular case, we decide to make 2 separate bridges from central incisor to the first bicuspid in both sides in zirconia frame, and the technician made a monolithic structure on lingual interproximal areas, but buccally he made room. He made room for layering with porcelain. This was the try-in of the 2 zirconia bridge, and you can see that the margin failed to be precise. They were a little bit too long, the 2 central incisors, and then we want to modify a little bit the canine on the right, in your left. So the technician made the final ceramization, the layering of the 2 bridges. You can see the 2 bridges on the articulator, and then you can see the tissue and the abutment immediately after removing the temporary. At the time we go to cement the 2 bridges, and then these were the cast. This is the try-in of the bridge. So it seems that the look of the patient is improved. She's very happy. We are happy as well. And the gingival tissue are happy as well. So the ortho treatment is going to finish. And this is the bridge. This is the incisal edge and the relation with the lips of the patient. And then at the end, after completing the ortho movement, we took an ortho, a digital impression in the lingual part of the lower incisors, and we made for this patient, we made a resin bonded 3D printed splint on digital impression. So this was the splint, and these were the final restoration again. And how we go to cement? When we have zirconia, we go to cement with as a conventional bridge. So zirconia is an aluminum oxide, a metal oxide. So we go to lute usually with glass ionomer. We don't lute adhesively, and we don't use self-adhesive resin cement. In the lower, we go to lute the splint, of course. We place the rubber dam. We use the microbrush in order to control excess of cement during after setting it, and etching, luting, and you can see after removing the rubber dam. So this is the patient after 1 year. And now these are the protosive movement. So here we have an endodontic treated tooth that was restored in advance of our treatment with a post still in place. Who care about that in case like this? Or if I had to treat it and then I extracted a tooth that in case must be endodontic treated. So if I start that treatment and then extract the tooth, the patient doesn't pay the endo treatment because then we have to extract it. So we have to consider, these are the perio charter after the treatment. And this is the final smile of the patient. And after 5 years, the situation is still like you can see in this picture. These are the emergence profile and teeth for this patient. Okay, now let's go through our story. We may have high aesthetic needs and severe dental wear. So that is another important situation. We have another lady around 50. She's a teacher in high school, married, and the chief complaint is, I want to make more beautiful my smile and stop documentation on my lower left crowns. So personality, she's anxious but positive, moderately collaborative and motivated, high expectation about, firstly, number one, aesthetics. She smokes 10 cigarettes per day. She has a parafunction, and she received recall of oral hygiene and the restorative treatment and crown. And the last one, dental treatment, was 1 year ago, the professional oral hygiene. And she brushed twice per day, and she doesn't use the floss. So this was the mouth of the patient. You can see protosive lateral movement. Excursion of the jaw is very limited because of the wear. and you can see that she arrived back to the office for a deep decay on 1.5, and she had pain, and she had also some nose around the 3.6 and 3.7, and you can see that many teeth are already crowded. So the number 15 is a tooth that can be restored, endodontic, can be endodontic treated and then restored without big issue. The number 36 and 37, they are so compromised as residual structure of the crown and the complexity of the endo treatment, and then the marginal seal was lost, and then the local interdisciplinary conditions and the complexity of the treatment. All these parameters suggest us to extract this teeth. Then we went through the Florida probe, and we noted some areas in which there were some probing around 4 millimeters, and this was the sextant of the upper arch, and we made a digital smile design for her. You can see the original smile on the left, you can see the DSD without periodontal surgery, and you can see the DSD with periodontal surgery. So she decided, we show because she was not so happy to get surgery, perio surgery, but we want to show her the gummy smile, how can be corrected. So we went through Facebook, a cast mounted articulator, as we usually do. We made a wax up, and we noted that the vertical dimension was missing only in the lower teeth, whilst on the upper teeth was planned to make longer teeth incisively, nothing else. So this was the wax up in the lower, and we made the mock-up. We made the mock-up for this patient in the lower teeth, and you can see that we tested lateral and protective movement with the mock-up. Everything was made really well under control. We had a very nice protective movement or protective guide, and in the lower central picture, lower line in the central picture, you can see, you can appreciate the increase of vertical dimension on lower incisors, because we took out in the two incisor on the right, on your right, and you can see on the left the length we would like to have for these teeth. So this was the treatment planning. The treatment planning was very complex. Of course, we start to do endo treatment to remove the pain of the patient, but then we start the full mouth rehabilitation, oral hygiene and root planing, build up with fiber post the 1.5, extraction of 3.6 and 3.7, and then to replace it with 2 implants to remove all existing upper and lower crowns, preparation for single crown or canine and bicuspid in the lower that were not treated, make a temporary on upper and lower teeth, crown lengthening on 4.6 and 4.7, place a second temporary, and then make the final crown in the upper and the lower, and the final screw on implants crown on 3.6 and 3.7. This was the radiographic control of the abutment at the closer impression time and polyvinyl siloxane impression of the 2 implants were placed. So here you can see some steps to make the two screw crowns, and this was the final restorations for these ladies. So we extracted two lower molars without retreating them, and we solved the problem of wear, and we solved the problem in particular of the aesthetics for this patient. So this was a control, and you can see the relation between the crowns and the periodontal tissue after 4 years. So when we look this patient about periodontal parameters, we still have some small probing of around 4 millimeters and 2 bicuspid in the upper, but everything is under control. And I recall all the endo treatments are in good shape independently if I place or not post. So you can see how the aesthetics changed. We may have functional needs with a long span bridge in unfavorable occlusion environment. Or we may have a compromised function due to dental wear. And let's see a patient like this. On this patient, what can we do? On this patient, you can see that we have no teeth anymore in front teeth. This patient was grinding the teeth, moving the lower jaw into S3 and grinding the upper teeth. So what we need to do? We need to make wax up on these teeth, and then to make a temporary. Then we decide to make endo treatment and build up of the upper front teeth, step by step. And then you can see that we took an impression, making pressure through the light impression material, through the temporary and the cotton rolls on the tissue as a retraction technique, a gingival retraction technique. We took the impression. These are the final polyether impression. All the prep were vertical prep. Here you can see the scanning of the cast, of the original cast, and how the temporary was designed. Here we have the final bridge for this patient. Everything was done in one piece, zirconia bridge. During the try-in, we check the occlusion and the fitting of the bridge, and we finalize the case. We can have also tooth as abutment of a full mouth rehabilitation. And look this patient. On this patient, we have a molar, a third molar in the lower jaw, and look the lesion around the third molar on the left. So we had to extract this tooth, and there was a big cancer to the bone around the third molar. So this was the CBCT, the dental scan, showing the lesion. So the patient had received a piece of prosthesis to build up, and because the occlusion was not recovered, was not remade or rehabilitated, so the patient had the malocclusion and screw out the prosthesis that was made. So we have to remake the project, and our oromaxillofacial surgeon remade a new prosthesis for her. So from this yellow one, they made this, and in one part is going to be fixed to the condyle, and from the other part will be fixed to the mandible. So this was the prosthesis, and the DIMA, I mean the guide to place to make the hole for the screw. This was the final titanium prosthesis, and the time in which was placed in the patient. So this was how it appears in the CBCT and how I received the patient. Now the patient has to be rehabilitated. These were the upper and lower arch, and you can see the occlusion. There was no occlusion. She was just chewing in front teeth. So we have to look X-rays, and then the 27, the upper second molar, was had some complexity of treatment planning and functional need, but the other parameters were good. So then we designed a new upper teeth, an upper bridge. So was made a 3D printed full arch temporary restoration that can be also the mock-up. And we prepped the upper teeth. We scanned the upper teeth for this patient. And this was the frame made on zirconia for this patient. And then the wax up on metal, on alloy. Then with raising, we reproduce also the occlusion and the incisal edge to make a phonetic try-in. And in the lower, we decide to go for a removable partial denture with 2 clamps. So we went in the mouth of the patient, and then we placed the final upper bridge, and in the lower, the removable partial denture. And this was the final restorations. And the 27 was endodontic treated, as you can see on the picture. Then we move to look the mouth of the patient. And we have to look local interdisciplinary condition, because pretty often we may have some complex treatment that have to put ourselves thinking, what can I do? Can I do crown lengthening, ortho extrusion, or what can I do for this patient? The main involvement is endoperio restorative prostome. So we have a single bicuspid with endo treatments. We place, we do endo treatment, we place the screw, and then we do some ortho extrusion, as you can see in the second X-ray. And after that, we place the rubber dam, and we go to make the build up. We make also a small crown lengthening, and then that is the step-by-step, the bonding procedure, bonding luting procedure for a post. for posts. And after the build-up, still under rubber dam, we prep the abutments, and now we have our abutment ready to take impression. And then to complete, as you can see on the right, the procedure. So this was a case with some, I would say, interdisciplinary needs. Then we may have teeth. This tooth was with an endo complexity and outcome. The coronal cedar structure vertically was not so much, had a complexity of treatment planning and local interdisciplinary conditions. So it was a tooth that, according with our diagram, can be extracted and replaced by an implant. But if you can manage both endo, ortho, perio, and restorative, you can try to keep it. Then we go into the tooth. When we go into the tooth, we have to look firstly the aspect about endo. We have to look endodontically if it's a vital tooth, if it's a necrotic, single root with periapical lesion, or a multi-root with periapical lesion, complex anatomy, calcify canals, additional canals, retreatment, and complex retreatment with modify of the root anatomy. Now, who is going to make endotreatment? We may have, in some cases, endodontists making them, but in many other cases, probably the wide majority, these are made by dentists, by the same dentist that is doing prosto. Or, like I'm by myself making endotreatment on my prosto patients. So these treatments are made by myself. Let's see vital tooth. Here we have a molar. And excuse me, I now focus the attention on, do I post or not to post? Now, when I'm on the single tooth, when I arrive to the single tooth. Now, I have a molar with a complex anatomy, but with a vital tooth with pain. So I made my endo, or in this other lower molar, I made my endo, and then I have a lot of coronal cedar structure. I go for build up with Everix flow, that is a reinforced, fiber reinforced flowable resin composite that can is reinforced with a piece of fibers that are the same fibers that you can find inside the fiber post, and he can make a good bond and can be well bonded to the dental structure, can fill the first part, the first 2 millimeters of the root canals, having some retention, micro and micro retention, and now then we go to cover both teeth with crowns, partial crowns. In this case, these are LISI crown, LISI partial crown, so lithium disilicate partial crown. Here you can see step by step. So we clean the chamber, and then we place rubber dam, wedge, and matrix, and then we go for the build up. And this build up is a sort of temporary build up that can stay in place for some time, And this is, later, we prep for an onlay and we go to cover with an onlay this tooth in which we do not place any post. Then we have to look necrotic single root with periapical lesion. So when we have teeth like this bicuspid, so we have necrosis, are easy case and can be restored accordingly with how much residual coronal structure remained with or without the post, but must be covered. Any bicuspid after endotreatment must be covered by crown. Or another single tooth in which there was a ledge, you can see, difficult to reach the final apex, the anatomical apex. Anyway, that was done, and then because the structure of the tooth was still sound, so in this particular case, the hole to the access to the root canal was just filled with composite and without any crown. Then we may have necrotic multiroot with periapical lesion. So we have on this tooth, we do endotreatments, and then we may build up with average flow, just placing 3 millimeters, filling 3 millimeters of the distal roots of the distal canal with the flow ball, and then build up the coronal part, or you can place a short post if you like. Doesn't matter. When we have a complex anatomy, in particular additional canal or calcified canals, so in this particular case, we have to look what happened. Here we have a difficult, very difficult case in which there are 2 canals and central incisors, so, and it's very difficult to reach it. When we have calcified canals and additional canals, we must be very prudent to place post, and I would say I avoid always to place post in complex anatomy. About retreatment, retreatment can be easy or can be difficult, but doesn't change so much for us. The first thing, the retreatment must fulfill good outcome before restoring it, restoring the tooth or the teeth. Here we have a big periapical lesion, so we have to retreat it, and then when the teeth were healed, so we can go for restoring. And in the canine was placed the post, and in the incisors, the post was not placed. Or in a molar, in which you can see retreatment. So this was an ugly endotreatment, the first one. So we regain the apex and we close it, and then we restored the tooth with build up and crown. Or here, the molar, you can see the pre-op in the upper left picture, and then you can see step by step till 1 year in the first line, and in the lower line you can see these teeth, bicuspid and the molar, 10 years later, 13 years later, 16 years later, 18 years later. And this tooth has a crown, and this tooth has a post in the palatal roots, and no post in the buccal roots, of course. Or another one in which you can see that was placed the post originally, and the post was removed. This, when we place a post, we have to think that the removal of the post pretty often for endodontists is pretty difficult. and risky. So the endo was redone, and then no post at all were replaced. The build-up was made through gutta percha and then flowball on the coronal part. Let's see complex retreatment with modification of the root anatomy. That means that we have perforation. So we have perforation here, and because the screw, and because the perforation and the resorption, internal resorption of the root of the center incisor. So we decide to go for gutta percha in the apex, and then MTA, and then gutta percha again. So when we do this kind of sandwich technique, we do not have room, or in particular in apical direction, to place the post. And so we do not place the post at all. Or another case in which we have endo treatment and build up with crown without any post. What about the coronal pseudostructure vertically and horizontally? We have to look for vertical coronal pseudostructure if we have 4 coronal residual wall, 3, 2, 1 coronal residual wall, ferrule or no ferrule. When we have a situation like this, we are restoring the single tooth, okay? We are concentrating in the single tooth. And also, we have to look at the horizontal coronal pseudostructure. So if they were cervical lesion, and in case they are, the entity of the cervical lesion, and how much tooth coronal structure was removed by the opening of the pulp chamber and the way to do the root canal treatment. So in some cases, we may have very limited amount of coronal structure vertically and horizontally. This makes the tooth in a very difficult situation. But let's see some cases. This is a situation in which we have 4 walls, periapical lesions, and there is not cervical lesions or excessive internal structural removal due to endo or previous conditions. So we made our endo treatment, and then we age, wash, dry, bond, and we, after luting, after curing, like curing the bond, we fill it with Everix flow, the bottom, the first part of the root canal and the bottom of the cavity, and then we build up with microhybrid genial posterior resin composite material, and we made temporary our restoration, giving the time to the periapical lesion to heal completely, and then we went through again and we made we covered the cusp with a partial crown, a lithium disilicate Lisi crown. Or we have a canine with 2 canals. We have 4 walls. So again, we fill it the coronal cavity only with Everix flow, but no post at all. We don't need post. Sometimes we have 3 residual walls, like in this bicuspid, but you can see that the other 3 walls are still sound. So we place the rubber dam, the wedge, the clamp, and then we build up into the root canal and the first part of the interproximal wall, and then we completed the build-up with microhybrid resin composite, and we left the patient like this, and then after a period of time, the patient came back, we prep, we want to cover the cusp, and then we prep an onlay, and we made the final luting, and you can see to recall this patient. Another similar case in which we had 3 residual wall that can be useful for build up without post, and I already show you this case. Or another one in which we did not place any post, and now we build up, we prep for partial crown, temporary partial crown, lithium disilicate, LISI crown, final crown, and then on the cast, luting procedure, and the final restoration in place. Another single case in one wall, sometimes we have only one wall, and we are really under pressure to keep the tooth in place because this canine is the abutment of a clamp of removal partial denture. So we have a cervical lesion that should be restored. So we go for endo. We found this, we had a lucky shot on catching this delta, apical delta, on the X-ray. And anyway, we build up with flowable material, reinforced fiber, reinforced flowable composite. We made the crown, and we kept in place the clamp and the old removable partial denture. Another case in which we have one residual wall in this bicuspid below this old crown. After removing the crown, we made endo treatments, build up, and then we finalize with a post in this case, and then we made the final restoration on top. Sometimes we have only ferrule. Only ferrule means that we do not have more than few millimeters of dental structure coronally. So we build up this tooth with with posts. We make longer the abutment, and then we finalize our restorations. Or no ferrule at all. When we have no ferrule at all, is a sort of hero. The dentists want to keep these teeth like this. Very short root, very wide root canal due to the extensive prep of the roots, in which there was placed a cast post and core and crown, and there is no ferrule at all. So this was the old crown. So we put under rubber dam, and we found out that the apex of this tooth was open completely till 80 of diameter, 0.80. So we place MTA on the apical part, then we place some gutta, and then we build up shorter with fiber posts. After making the build up, after the build up of the abutment, we finalize a temporary crown, and you can see MTA apically, gutta percha, and fiber post. Anyway, this tooth, before finalizing the crown, I was waiting for at least 6 months, had a fracture, and I had to extract the tooth. Vertical fracture, was too weak. I lost time. I lost money trying to save a tooth like this. Why I did? Because I did not follow the diagram I'm talking about. Or another case that was made in my school, the patient came with an emergency, so there was no ferrule, no walls, build up, and then on the canine there was a cantilever for the first bicuspid, and after 6 months the patient came back with a fracture. So here you can see the cantilever, and this tooth went to fracture after 6 months. This is the fracture, and we have to extract it. Never leave cantilever on an endodontic treated tooth restored with a post. It will fracture in a period of time. Something about the coronal cedar structure horizontally. Well, we may have teeth in which horizontally we have very small amount of coronal structure, and this can be due to class 5 buccally, class 5 palatally, and also you can see on the drawing on the right, on your right, there might be the opening of the root canal, and the chamber may destroy a lot the coronal structure, and this make much weaker the tooth. Also, keep in mind that when we go to make our crown, our prep and our crown, the finishing line of our crown will end pretty often on the composite we use it to fill the class 5 lesions. So let's see a case. Here we do not have a cervical lesion, but we have a very wide removal due to endo treatment. We place, was anyway 3 walls, we place a post, and then we prep and we went to cover the cusp, and then we luted a lithium disilicate partial crown. Here, another case in the lower, we have to make endo treatment in the second bicuspid, and after making endo treatment, we go to restore, step by step, etching, bonding, adhesive, flowable, build up, microhybrid enamel shade, composite, and the final restorations. So here we made a sandwich technique using the microhybrid, the fiber reinforced flowable composite as a first layers, and then on top microhybrid resin composite, Everix Flow plus Genial. And this was the 3 walls. And then we place at the end a partial crown on top. This was the prep for the partial crown, and then this was the lithium disilicate crown after being luted. Other 2 cases, these 2 teeth had pain. I had to treat it endodontically, and then I had to go to restore. So firstly, I go to rebuild up the distal wall interproximally. I modify class 2 and class 1. So then I go to fill it, and these 2 bicuspid were restored without post and were prep with a vertical prep to receive 2 crowns, single crowns are in place, no post. So here we have another 3 walls with a slight cervical lesions, but not so much. So we build up step by step. Here you can see the build up, and then being a bicuspid, we go to cover the cusp with a lithium disilicate only. We want to protect the root of endodontic treated teeth from the occlusion, from grinding. Here we have another 3 walls that will be covered by a lithium disilicate Lisi crowns. So step by step. But then we may have some cervical lesion that require restoration and absence of extensive internal structure. Here we have in this anterior teeth some class 5 lesion. They were cleaned, I would say, during the prep. Then we have to make endo treatment. So we made the endo treatment, and then we did the build up with etching, washing, bonding, drying, bonding, light curing, and then flowball, fiber reinforced flowball, light curing, and the job is done. It's already in abutment, so I don't need to place post. Here we have another important, nice case, in which we went through prep for aesthetic reason. This tooth, this was made in clinic, my school, in order to make a laminate. Then you can see that the endo treatment was redone, and my student decided not to go for a full crown, but for partial crown. You can see the 2 crowns in place, the crown in place after being luted, the laminar veneer, and then after 6 months the patient came back, and because of trauma. So now we have a cervical lesion requiring restoration and presence of extensive internal structure removal due to endo or previous condition in this case. So we have only 1 wall, more or less. So we did our build up. In this case, we placed a post because it was not so much the coronal silver structure, and we made a new full crown, and this was the final result. Another case in which we do not have a cervical lesion, but there is a wide a big removal of internal structure. So, and we have only 2 walls remaining. So we did the build up layer by layer with this fiber reinforced flowball composite, and then this was after the build up. You can see on blue on the X-ray the position where the flowball was placed. And this is another 3 walls, upper molar. We made our treatments, and then after that we went to build up again without placing posts. So as you can see, I'm not placing so many posts. When I can, I avoid it. Another limitation to use post might be thermofill or similar system. Anyway, on this molar, we were going to treat it. When I treated, I made firstly the thermofill on the, I made first the treatment on the second molar, and then on the first molar, I used a thermofill to seal the apex and to fill the root canals. And these were the final endodontic outcome. And then we remove the amount of the remove of the old restorations and decay and the temporary restoration. So you can see how much coronal pseudostructure remained. On the first molar, we have a sort of ferrule, and 3 walls on the distal one. But we have a chamber that is pretty retentive, so we prep very gently on the second molar, the first part, the first 2 millimeters of the root canals. We did also in the distal roots of the first molar, but we didn't do on the mesial roots because we used thermophil and we do not want to interfere with the thermophil. So then we etched, and then step by step we build up the 2 restorations with a wide base of fiber reinforced flowable material, and we selected the dentin shade, and then we put on top enamel shade microhybrid resin composite. This was the two restorations. On blue, you can see where did we place it. The flowable material, the build-up, and the patient remained for till now with 2, for economic reasons, remained with these 2 restorations without covering. But I suggested to place 2 partial crowns on top. This was another case in which we have no ferrule on one tooth, and then we have 4 walls in the central X-ray, and no ferrule in the other bicuspid. So in the canine and the second bicuspid, we do not have any walls. In one, no ferrule, and the other one just ferrule, and 4 walls in the first bicuspid. So we build up these teeth, and we build up the teeth when there was no ferrule or ferrule in the canine and second bicuspid in post, and no post at all, of course, when we had in the first molar, first bicuspid, in which we had residual coronal structure remained widely. What about the restoration marginal seal? Well, the marginal seal is a key point. We know from Ray and Trope that endodontic success rate can drop from 90 to 18 if coronal restoration is poor. So the marginal seal is very important also for as endodontic to keep good endodontic, to achieve good endodontic outcomes. And this observation was also confirmed by the Franklin Tay group, that they made this systematic review and meta-analysis, and he showed that successful long-term retention of the endodontic-treated teeth is dependent on adequate treatment in both the endodontic and restorative phases. So when we do seal, when we want to achieve seal, we have to keep in mind that we have different kinds of substrate. We have enamel, we have sclerotic dentin, superficial dentin, deep dentin, and cementum dentin. So these 3 dental substrates are completely different, from almost inorganic to almost only organic material, substrate. And the prisms are arranged with a sinusoidal direction. They are not straight. And in the area we want to seal, in the bottom of the class 2 cavity, they are parallel, cut parallel to the long axis. And when we have a small amount of enamel, must be kept everywhere, because that can be sealed by bonding steps. But inside we have, in cementum dentin, we have only a very organic tissue, and tubules are visible only 300, 500 microns within, internally. So the first 0.5 millimeter from the bottom of the cavity, from the margins, are on cementum denti. And this area is very organic and cannot seal. And this will be much worse when we have a full crown prep in which we have cementum dentin 360 degrees. Keep in mind, any restorations that are luted or cemented below, with a margin below the CAJ, will never seal. For sure, will have leakage. The leakage can remain unknown in 90% of cases. The patient doesn't have any symptoms, and but we cannot pretend to seal the cavity when the margin is in C below the CAJ. In this area, we may have an open margin, and the open margin might be colonized by bacteria. How we can treat dentin? Here there are two milestones, two giants of bondings. One is Nobuo Nakabayashi with me and Professor Tim Watson. Nobuo Nakabayashi passed away some months ago. And in the other picture, you can see Professor Paisley with Professor Bresky. So these two gentlemen plus Franklin Tai, they really made the pillars of modern adhesive dentistry. And in particular, Franklin Tai showed that the simplified bonding system, they act as a permeable membrane, so they don't seal by themselves, but they can seal only when they are covered by flowable material or unfilled bonding resin. Hybridization of dentin. We talk a lot about hybridization of dentin. This is a very important issue, but consider that hybridization of dentin is nothing more than to apply the bonding when you make a class 2 restorations. So we work a lot on the previous millennium on this topic in the 90s, and we publish a lot of papers. And then more recently, the new millennium with PDF, internet and PDF available, the group of Pascal Magne started to work on that and propose it as a news in dentistry. So anyway, when we do hybridization of dentin, we do when we apply any bonding system. And when we do the cervical margin elevation, the cervical margin elevation theoretically consists on a coronal elevation of a deep interproximal margin by applied bonding of resin composite material. That is nothing more than to make the first layer in the bottom of the cavity interproximally of a class 2 restorations. So you hybridize the dentin and you make the cervical margin elevation when you make the first step of a class 2 restoration. So now there are many papers that they clearly show how the procedure for cervical margin elevation and hybridization of dentist can be used. So it's a technique that is probably pretty easy, not so difficult. And anyway, there are a lot of papers. We, as I told you already, we contributed on this field with many scientific papers, and it's something that we do really routinely, really daily. So I would like to avoid to go too much in depth and describe this technique and the science of this, because I don't want to stress too much. Anyway, always remember that when resin composite materials shrink, well, when they light cure, they shrink, and the shrinkage is the maximum stress produced by the shrinkage is, you can see on red on the pictures, is located at the bottom of the cavity, interproximally. And in that area, remember that we have the area that the patient clean less than any other, because has to be cleaned with floss. So anyway, this is the movement may have the composite during the setting, during the light curing, and this create stress because it's shrinking. So I would again not to touch too much cervical margin relocation, and we study a lot also recently, publishing some papers. What I want just to let you know about that is that, let me go fast because I'm going all otherwise too long, that you have to control and finish the margin of your cervical margin relocation. Everything must be done under rubber dam. There is no literature at all, or really few papers on this. And also remember that in this area, we have also degradation of the hybrid layer. So the hybrid layer, the bonding is not for life. And also there is hydrolysis due to cryogenic bacterium of the dental resins. So in this area is the most difficult area, and that is the most difficult area to be cleaned by the patient. So we have to try not to be too much into the sulcus. Why? Because in this paper, that is a paper that we made a few years ago, is the influence of cervical margin relocation, periodontal health, 12-month result of a controlled trial. So we noted that testing the patient in the two sides, cervical margin relocation was the test site, and control without cervical margin relocation. We tested with bleeding on probing, and we noted the higher incidence of bleeding on probing around teeth treated with the concept of cervical margin relocation, and in coincidence with deep margins placed at or closer than 2 millimeters from the bone crest. So 2 millimeters from the bone crest. And then we did another study looking to the cytokine profile of the bacteria in order to see if there were inflammation in the sulcus, and we noted that inflammation was immediately acute, and then the product, the cytokine that are products of the inflammation, they became stable but always present as a chronic starting chronic periodontitis. So we have to stay 2 millimeters from the bone crest, because otherwise we might violate the supracrestival connective attachment that is more or less 2 millimeters up the bone crest, and don't use the CMR in order to replace the perio treatment. perio treatment must, when there is the need of perio treatment, please do perio treatment. Or sometimes we have margins in the enamel. Let's see margins. Let's see this case. We have in this patient necrosis of the central incisors, and the patient, of course, was grinding the teeth. As you can see, we make endo treatment. We made our filling, endo filling, and then we went to fill with Everix flow the hole we made to reach the chamber and the root canal. We didn't do anything else. Another case in which we have 4 walls and we want to seal, we are in the enamel again. We made, in this second molar, we made the endo treatment is C-shaped canals. And then you can see here how the patient destroyed the glass ionomer we place as a temporary restoration. So you can see the cavity is very big. We don't need any post, and we do step by step. We fill the root canal and the chamber with composite that was a flowable, fiber reinforced flowable resin composite, and then we prep and we cover this tooth with an onlay in lithium disilicates. And this was the final restorations, final view. Another case in which we have a young patient with short roots. You can see from before the treatment and after the treatment on the right. And this was the step. Here you can see the prep of the onlay impression that was made traditionally, and this was the final lutein steps and the final restoration in place. Or another case in which we have in the upper 2 bicuspid, and we cover this 2 bicuspid with onlays, and at the time we luted 1 by 1. So no post, resin composite pin, and direct restoration in wide and deep, if there is a wide and deep chamber. Amount of remaining coronal residual structure and wide pull chamber can permit not to use any posts at all in posterior teeth in particular. But what is important is to cover the cusps with onlays. Cover the cusp and you protect your endodontic treated tooth. Protect from occlusion. Here we have another case. We have 2 old and ugly resin composite crowns that one broke in the bicuspid. So we remove and we reprep the bicuspid, and then we took a digital impression, and then also we made a traditional impression in order to made Elisi, and then to study this case. Consider that in the last 5 years I made almost routinely digital impression and analogic impression, traditional impression, in order to compare and to follow the development of digital intraoral scanner. So this was at the time of the luting. You can see some luting step, always under rubber dam, and then the final the final restoration in place. And then we did the same on the molar, also in this molar, no post at all. We use a Lisi press crown. You can see the impression, digital impression, and we made everything through with digital workflow for this Lisi press. We duplicated, we printed the STL file impression, and we had the traditional one, and then the 3D printed abutment made with two different intraoral scanner. And when we tested all the crowns, all three crowns, the two made by the scanner and the one made traditionally, were having a good fit. This was the final restoration after being painted, and then the step-by-step to lute fluoridic acid inside the crown, washing, then we use the multi-primer, that is a sealant, and then we place the cement, and then we go to lute under rubber dam, step-by-step, etching, bonding, light curing, place the crown, remove excess, and complete the light curing. And this was the final two crowns in place. So one was made on Lisi press, and the other one is a Lisi block. So blocks made on lithium disilicate for chairside. And the same, and the result, I would say, is, in my view, very good using both formulation, press and block. So in a case like this, how we build up the 25th? Is a post needed? So in this case, we have to post. We have to build up, and we place in 25th, and then we made also the 24 and the treatments, and in this in 24, we didn't make any, we didn't place any post. Sometimes we have margins placed deeply into the sulcus. You can see this particular case, we remove this crown, and then you can see that the treatment, the tooth is already endo-treated, no periapical lesion, there is already a post inside. So I re-prep the abutment, I check the margins, and then I changed a chamfer in a vertical prep, and then I placed the temporary. With the temporary, I try to manage the tissue to have the same level of the other incisor. So we make a little bit shorter in this case. So here you can see the X-ray, and then you can see the tissue that was healing, and then after removing the temporary, and you can see the final restoration in the lower down. But I didn't touch the endo treatment. So before and after. Another very complex case was the one I made for this patient. This patient had a fracture, vertical fracture of the crown, but not of the roots. So we went, we made the endo treatment because the patient had pain, of course, and then you can see the fracture, how it can move. So I kept in the position the fractured piece with composite, and then I made bone remodeling with a diamond bar. So I made I prep a little the roots. I made the vertical prep, and I make the abutment. So then I tried to keep in the position the piece was fractured by etching and bonding. This was the result. And then on top of this, I placed a temporary. But then after removing the temporary, the pieces that was fractured and bonded and that I tried to bond came out. So now I have to build up the corner part. I placed the post and then etching, bonding, glued the post, build up, and then to prep, and I remade my abutment, and then I finalize with a final crown. And this was the final result. So I went through some example of all the steps. I am sure that I touched also the point that we have the possibility to going in this staying, I would say, on this diagram, we may have information, and we may understand how difficult can be the case, and in particular, we may decide. We have to make this is very important for a decision-making process in order to know that anytime we have more than one parameter of these 8 parameters on red area, more than one means at least 2, extract the tooth. If you have only one, you can try to save the tooth, but with some difficulties. If you have all the parameters in green or yellow, you can go straight, and if you do everything properly, you'll have great success. I will stop here, and I want to thank you for your attention. Let's see some questions. How to determine the type of prep for each tooth? Why to separate bridge and it's more aesthetic? Okay. Probably these questions were made on the first patient I show you, in which I prep. Let me go back and I can catch for you, and I can answer having them in front. Okay. Now, they were already crown on the lateral, and that was a chamfer. So we just cleaned the abutment of the lateral and nothing else. The 2 central incisors were prepped because the gingival tissue was in perfect good health with a small chamfer, and in the bicuspid we prep a small chamfer buccally, but as you can see here, probably interproximally, in order to recreate more room for the crown, we prep vertically. So when I prep vertically, I can modify the inclination of the abutment, and I can make, in this particular case, more room for the crown. Anyway, going back to your questions, in which you say how to determine the type of prep of each tooth. In this case, I told you, but okay, now let me answer one by one, but you can put questions and I answer you. I place 2 separate bridge because it's easier to manage when we go for layering porcelain. It's not more aesthetic, doesn't matter, but it's easier. And then in case you may have a problem, for instance, an endodontic problem, and you have to remove a bridge, you remove just one bridge and not both, and not wider bridge, so can be more conservative for the future. Why I did not you make bridge without extraction of the canine? I didn't do this because if you see again this X-ray, not this one, excuse me, the previous one, here and here. Here you can see that the canine is positioned oblique, so is closing the position of the root is as a canine, but the crown was in a lateral position. So the tooth is compromising aesthetics. If I keep it, I cannot place here the tooth. I cannot replace the missed tooth because was not permitted by the position of the roots. Also, I extracted because there were already periodontal lesions, so was a tooth that was unsafe or unpredictable as outcome for the future survival of the bridge. And that was decided, of course, with the patient. Any other doubts or questions? Okay, so if there are not other questions, I want to thank you so much, and hopefully we'll see again pretty soon on this internet. Thank you. Have a good evening. Bye-bye.